morning. Can you hear us, Emmanuel? Good morning, everybody. Thank you for joining. Sorry about the delay. Today, our presenter is Dr. Steyn. Dr. Steyn completed a medical degree in 2010 at the University of Pretoria. She was then appointed as a registrar in neurology at the University of Witwatersrand in 2015 and completed her M.Med focused on primary headache disorders and qualified as a neurologist. She also holds a diploma cum laude in clinical neurology from the University College of London. In 2020 and to 2011, she completed a clinical fellowship at the University of Cape Town at Groote Schuur Hospital, focused on neuromuscular disorders such as myopathy, neuropathy, myasthenia gravis, and motor neuron disease. She has published numerous articles in the field of neuromuscular disorders. Currently, she's also involved in teaching in the field of neuromuscular conditions in collaboration with the University of Zambia. Dr. Steyn is based in Suite 208 at Midstream Hill Medical Park next to Midstream Mediclinic. Thank you so much for coming to present with us.
I had to go to so many universities because I was passed away. So that's just my opinion. Okay, so I actually just wanted to title a presentation last night in the midnight hours, but then I thought this is so much more fun. So I'm going to talk to you about acute headaches because I think it is something that we see very, very often, and it is something that needs to be managed correctly. Otherwise, your patient is going to become a chronic headache. So, without further ado, I just want to move on. Okay. So, the stats say that about 2 to 4% of casualty department patients will come in with headache as their primary complaint. Headache is ranked as the third highest cause of disability worldwide. And, you know, a very, very small amount of those patients will actually have a life-threatening cause of a headache. But that's the tiny number of patients that the headache is actually serious. They can get into trouble quite quickly. So they can either die or they can go blind if you don't recognize it and treat it appropriately. And then there are really basic principles not to actually miss what we call a red flag headache. And it's basically just getting history and just examining the patient. By just doing those two things, then I think about 98% of patients won't be missed. So, as far as I'm concerned, there are only two definitions that are really important. So firstly, we have primary headache. So a primary headache is like a migraine or tension type headache. So that is the disease. The headache is the problem. There's no underlying cause for it. There's no tumor or meningitis or whatever. Secondary headaches are disorders where the pain is from an underlying cause. And those are the typical patients that you don't want to miss. So, in terms of pathophysiology of headache, so I think we still don't completely understand the entire process, but we know that there are some nociceptive neurons that are actually sensitized. It can be due to internal or external triggers, and then there's long-lasting activation of these receptors, and it can manifest as headache. So we also know that sometimes there's this inhibitory sensitization, which then leads to dysfunction of the descending modulatory pathways, and that is how patients with these chronic pain syndromes actually manifest, is because of this inhibitory sensitization of the pathways. So in a headache specifically, there's peripheral sensitization of the trigeminal nociceptive afferents, which actually innervates the dural meninges. And then there's an entire little pathway, hormones, neurotransmitters being secreted, and then in the end, you sit with your patient with a headache. So I don't know if you've heard about Snoop 10. So Snoop 10 is an easy way, if you see a new patient, just to sort of make sure that you're not missing anything dangerous. So the S is for systemic symptoms, including fever. So if there's anything else that just doesn't make sense, then this is a patient that you have to pay a little bit more attention and do a workup. If there's a neoplasm history, so if the patient has thyroid cancer or renal cell carcinoma, things that actually go to the brain, you have to definitely scan this patient. If there are focal signs and symptoms, including just decreased level of consciousness, you have to scan. If the onset is sudden or abrupt. So this is what we call a thunderclap headache, where the patient just comes in, it's like really a clap of thunder, worst headache of their life, 10 out of 10 from onset. That is a headache that needs investigations. Then if the patient is older than 50 years, so we know that the primary headaches, you are not going to get an 80-year-old that presents for the first time with a migraine. It just doesn't happen. So the cutoff is usually 50 years of age. You have to go and look what on earth is happening. Then we have these chronic patients that say, doctor, my migraine always starts like with an aura, and then it's 30 minutes. I can tell you to the T how their usual migraine is. But then they come in with a new kind of headache. So you have to listen to that because it might be something else. Then positional headache. So patients that tell you, the moment I lie down, my headache is like a 10 out of 10. And when I get up, I'm fine. So like if there's a high pressure component, or the opposite, a patient that tells you, doctor, when I go to the toilet and I stand up, I get this excruciating headache, so a low pressure headache. It's not common, but you need to just know about that. Then headaches precipitated by sneezing, coughing, or exercise. You have to investigate as well for obvious reasons. Then I don't know, do you guys still use your ophthalmoscope? So that is a very, very important skill, and I'll show you about that now. So if there's papilledema, I think that is one of the most important skills to have, because it is the only way that you can sort of indirectly see the central nervous system. And then if there's papilledema, you're going to find something on that patient. Then, of course, progressive headaches that just don't follow the usual rules. You have to think about pregnancy or postpartum headaches. Remember, you can still have preeclampsia postpartum. So just think about that as well. If you have a painful eye with autonomic features, like this patient that just comes in with like a with like a red eye or Warner syndrome, you will obviously scan as well. I'm not going to talk about trauma, but if there was a history of trauma before, so for example, there's an OPA from some of his care of midstream retired midstream, and he fell, and then slowly, he has a little bit of a headache, and then they realize he's not completely corpus mentis. Those patients, they are the gift that keeps on giving. Then in terms of pathology, if the patient is immunocompromised, and that is not just HIV, we have a lot of patients with autoimmune conditions that follow up here. You have to have a low threshold to actually work them up. And then patients with painkiller overuse. So we'll talk about what exactly is painkiller overuse, but there are patients that are drug seeking as well. So you also have to, even though they come for their pethidine, also have a very high index, because you start labeling them and then you miss meningitis. So okay, so this is just to remind you. So that is a PanOptic. I don't know if a lot of you have seen that. If you don't have a PanOptic, I will really advise you to get a PanOptic. If you are used to that tiny little ophthalmoscope, one of my friends actually says it's like when you look through that tiny thing, it's like looking through the door hole, and then when you actually look at the plan optic and you actually see the nerve like that, it is just mind blowing. So I do this every day in practice, and those are just sort of the gradings in terms of papilledema. I don't think I can go as far always to grade it like that, but it is an extremely helpful tool in clinical practice. So I would really recommend you getting a planar optic. There are some apps as well that you can attach it to your iPhone, and then you can actually take a picture. So yeah, that's available as well. Okay, so then there are some clues that this is a very low risk patient. So if the patient tells you, doctor, this is my usual migraine, don't worry, just give me the migraine protocol, I just want to go home. So those patients are typically not something to worry about. So if a patient comes in and they're completely worked up by either myself or Rabin, then I think, you can sit tight as well. Then, we usually do our scans, we usually counsel the patients. So I don't think those are the high-risk patients. And like I said, if the patient asks for a migraine protocol, remember our migraine protocol in casualty, it doesn't have any opioids or anything. And so it's not like they can get hooked to it. So I think those are safe patients. If you don't have any focal signs or symptoms, or if this is a new patient from Unitas or wherever, and they actually fulfill the ICHD classification for specific primary headache disorder, I don't think you have to worry too much. So this ICD-3, the link that I put there, it's a very, very nice tool. I actually have it open on my desktop on most days. And it basically just goes through exact criteria for headache. So it's 95% sensitive, specific. So technically, in a low resource setting, you won't even have to scan a patient. So at Barra, for example, if we work there, patient fulfilled criteria for whatever condition, then you could safely say this patient doesn't really need a scan. So it's a very nice tool to have. Okay, so then I'm just going to quickly talk about primary headaches, because I think there are 3 primary type headaches that you can see in casualty and ward, and then we can just say a couple of words about how to manage them. So migraine, just in terms of epidemiology, we know 12% of the population has migraine. It's usually females. It should decrease as you get older. So like I said, you won't get an 80-year-old presenting with a migraine. There's a higher prevalence in Caucasians, but I don't really know if we have proper data for Africa. And 70% of patients will actually have a first-degree relative with migraine. So just in terms of an aura, so remember, aura starts usually before the headache. It can start 5 minutes to about 60 minutes before the actual migraine, and you can have more than one aura, so they can follow on each other. So auras can be visual, so that's the most common one. The patient that tells you they have a scintillating scotoma, or there's some kind of visual symptoms, but it's always the same sort of phenomenon. And then you can have sensory symptoms. You can have a hemiplegic migraine. You can have if you've worked up the patient, they can have brainstem symptoms. And then it has to be less than 16 minutes, and then it's followed by the migraine with specific migrainous features. On examination, these patients are usually completely normal. Here and there, you can find a patient with Horner's or with hypertension or hemiparesis or sensory loss, but that's like far and few between. The migraine headache, we always think it's unilateral, but it can actually be bilateral and it can switch sides. So that's one of the things that happen. And then there are these patients that actually come to casualty where they have status migrainosis. And that is a headache that lasts for more than 72 hours. And usually their pain symptoms are debilitating. There can be a little remission in that 72 hours. So they can have like 12 hours that they don't have the headache, but it's a headache that just doesn't go. It stays. And then, like I say, the diagnosis, basically you can do a scan. You should do a scan if it's a new patient, but if they meet criteria, then you can sleep at night. So I think what you guys possibly see quite often is a migraine without an aura. This is now that international classification of headache disorders. So it looks like this. It's very neatly sort of put out. So they say you have to have at least 5 attacks. The headache can last anything from 4 to 72 hours. And then they must have at least 2 of those characteristics, where it's unilateral, it's pulsating, it can be moderate or severe, and it is usually aggravated by routine physical activity. So these patients will typically say, doctor, I can't work at the headache. With a tension type headache, the patient will say, no, doctor, I can push through. I really push through and I continue. A patient of a migraine will typically not be able to do that. And then during the headache, they must have at least one of the following. So they will have nausea plus minus vomiting, and they can have photo and phonophobia. And then again, it shouldn't be better accounted for by something else. So basic principles of treatment. So we know we have our little protocol in casualties. So we usually use NSAID. So you give your patient the Fulgan. I see Cornell started using the Pufalgan with the Brufen in, which looks quite nice. I think it's promising. I don't know what you call it. It looks like paraffin or something. That's a funny name. Paraffin. I think that's a good option to maybe give a patient in casualty. I like using, you can use either Levo or Razon. Just always look if the patient has risk factors when you use Levo. You will rehydrate the patient because usually they've started having nausea, vomiting. You give them an antiemetic, and I like using metoclopramide. I know we're always afraid of the extrapyramidal side effects, but metoclopramide sort of off-label also helps for the migraine itself. Our triptan, the availability is not as it was in the past. So we basically have Maxalt rizatriptan 10 milligrams that they put sublingually. And then I give a tiny dose of cortisone. So what I usually give is I give just Decadron, 8 milligrams. If you give higher doses, they tend to rebound. So that's why I use lower doses. Anti-epileptics, I like using Epilim or Valproate. You can use either 400 milligrams, 800 milligrams. There's no real guideline, but it works. And then if this patient keeps on coming back, then you need to start counseling them on preventative treatment. So if the patient has more than 2 migraine attacks a month, or the attacks are more than 24 hours in duration, and they have to use abortive therapy, so they keep on using Maxalt, then you need to actually tell them, listen, you need to calm down. We need to start you on something that's going to prevent your headaches. And I usually tell them, we can always stop the medication later when you go into remission, because people are for some reason very reluctant to take medication to prevent the headache, which is just mind-boggling to me. So what we usually use for prevention is we use antidepressant or anti-epileptic, and then you can also use a beta blocker. So our favorites, or the first line in terms of antidepressants, are just normal tryptoline, good old tryptoline, or you can use a SNRI. So we know that the SSRIs actually make migraine worse, but the SNRIs actually work better. So stuff like venlafaxine, desvenlafaxine, some duloxetine. So they work extremely well for migraine. And then the anti-epileptics, our first line is Toplec, and then our second line, if the patient is on contraception, you would consider giving Epilim. Epilim works extremely well as a preventative treatment for migraine. So that's usually how we go. If a patient has a very high pulse rate, then I like giving propranolol as well. So then it treats that little bit of anxiety, and just worked out. And then no opioids. And then I said yes, Tramadol, Sinaleve, and codeine or opioids. So I think the danger is And I see that with a lot of patients that come to the room. So the GP freaks out because now this patient has been here 5 times this month, asking for tramal drip or whatever. But the problem is they are actually causing the migraine to keep on rebounding. So you don't want to do that. Still pain, I love still pain. It works very well postpartum, but it has codeine in. It has very high dose of caffeine, so it keeps on rebounding. So be very careful what you give the patient, because some patients take it like very personally. They're like, no, but Dr. So-and-so gave it to me. That doctor is next to God. So they believe that if that doctor gave it, then it's okay to take it. So if I do use an opioid, which I rarely do, then I tell the patient, listen, this is a once-off thing. You will never ever get this from me again. And I tell them why. I tell them it's going to rebound, but I'm very desperate and you're going to get this one dose of something. And usually I give them a tiny thing, like a solid milk patchy or something like that rather. But that is very rare that I would actually use it, because it really does just keep on rebounding. Okay, so now in terms of medication overuse headaches. So also be very careful of these patients, because the definition is just if the patient uses more than 10 days of Bernardo a month, or 15 days of Bernardo and 10 days of triptans or whatever. I had a patient that actually uses Maxalt every day. She says, doctor, I'm so scared that the headache will come, so I just take it. And then I'm like, but you're going to get the headache because of your medication. So it's like you have to explore the idea in the patient's head as well. So it's very difficult. And then, like I said, be very careful of drug-seeking behavior. Okay, attention type headaches. I'm not going to say much about this, but this is that typical headache that we all get at the end of every week, where that's just like a tight band around your head, and it can last for 30 minutes to 7 days. So hopefully by the next Monday your headache is gone. So it's bilateral, it's pressing, it's moderate in intensity, and patients can usually go on with working or whatever. And there's no nausea, no vomiting, no photophobia. So this is a more benign one, but once it becomes daily, then you obviously have to also give them some kind of prophylaxis. And what works like a bomb for them is tryptophan. So tryptophan and also your antidepressants. Okay, and then cluster headache. So this is actually extremely rare. We actually have a patient now in CCU that has cluster headaches. But they're far and few between. You get very excited when you actually see them. The patient typically has ptosis. They can have like a full nose. They can have tearing of the eye. And what's very, very important in these patients is these patients are extremely restless. So where a migraine patient will just go and like lie in the dark room, this patient will pace around. They will just not be able to sit. So you need to just have a high index of suspicion. And typically they have this kind of a stabbing headache that can last for about 15 minutes to 180 minutes, they say. And some of these patients can have a couple of them, like 1 week they have them, then they come for a few between. So it's not always that we will actually treat them prophylactically, but you might see them. So the migraine protocol should work for these patients as well if you see them in casualty. And then what you can give them is just oxygen. So just put on a non-rebreather mask kind of thing. And they say you just pure oxygen should actually take it away. So that's just that. So the secondary headache. So this is the fun part. So you might recognize some of the patients because I use some of my old patients, but yeah, let's just see. So it's just very interactive case study kind of based things. Okay, so this is the patient that's called Cintas from birds. So the patient, you didn't do anything wrong. So the patient had, so the patient had a thunderclap headache and dizziness during sexual activity. So he reported to his wife that he had sudden severe neck pain and photophobia, had nausea, vomiting, and then sudden loss of consciousness and a seizure. So by the time he arrived at Brits, Scott intubated him, he took him to the scan, and then he was ventilated, intubated, and he was sent to us. Can you guess what's on the scan? Oh, wow, let's go. What do you think it is? So it was a subarachnoid. Yeah. So these patients typically have a thunderclap headache. They can have dizziness. They usually have severe, like sort of meningism, neck pain. It can be a periorbital pain as well. They can have visual changes and severe nausea and vomiting. And these patients deteriorate quite quickly. Usually it's a mist or like a cold type of aneurysm, and the prognosis is typically quite poor. So even if you do.
Is it a coincidence that it was during sexual activity?
I think it was, yeah. I don't know what he did. Used the extra. He wasn't a healthy guy. Yeah, so his blood pressure shot up. And what's interesting with them is they can also have their temperature shoot up, and then you think, oh goodness, is this also infection? But it's just because of the presentation. Okay, so this is a tricky one. Reversible cerebral vasoconstriction syndrome. So I've had 2, I think, ever. So they have these thunderclap kind of headaches, like a 10 out of 10 headache that just recurs. So it goes away, then they're like, okay, I'm fine again. And then this recurs again. So it's a very difficult one to actually catch in the act, if that sounds correct. So they can have relief for hours or days, and there might be a recurrent trigger. So basically, the list is extremely long of medication that can actually trigger this. So anything from like just usual antidepressants, but also exertion, emotional stress, etc., can cause this. And the neurological symptoms actually depends on if you have a little bleed as well. So what you'll see on the scan, so the scan of choice is actually CT angiogram. And what you get is, I don't know if you can see it, but we call it a sausage on a string. So it looks like a little borshiki, and then the knot. So that's how you actually diagnose it. But you have to go and look for it. It has to be like quite a smart radiologist to actually see it as well. And then they can have subarachnoid bleeds as well. So that's sort of the typical presentation. But like I say, it's difficult because sometimes the scan is completely normal when you scan them. So to catch it in the act is actually quite difficult. Then the cervical artery dissection. So this is the kind of thing that makes me not be able to sleep at night because you can really, really miss this. So patients, they can have had like just a tiny, like the seat belt touched my neck kind of thing, or I wore a polo neck. Kind of, this is really something that can happen. And patients at risk are typically these patients with connective tissue disorders or Ehlers-Danlos or one of those kind of conditions. And typically, they just come with prominent neck pain. They can have dizziness. They can have tinnitus. Tinnitus is very common with all headaches, by the way. They can have nystagmus. They can have, they hopefully, if you see the warners, that is a very nice thing. And then if you are able to hear a corroded bruit, I will personally come and shake your hand. So I think it's quite difficult to sometimes just hear it. I struggle. And then, yeah, so basically the presentation is just based on if there's a stroke or not. So what happens during a dissection is basically the vessel walls are compromised. So blood just sort of seeps in between the layers. So it makes like a tiny little balloon, and then one of two things can happen. So either you cut off the blood supply and there's hypoperfusion, and then the other option is that some of that blood just makes a thrombus and it shoots and you get your stroke. So it is it is a scary situation. So in terms of treatment of this, that I'm not gonna, let me just go back. In terms of treatment, so if a patient does come in with a stroke, then it's not a contraindication to give thrombolysis. So you need to still give it. If the patient, if it's like a cold case, they say if it's intracranial, then it's not wrong to give anticoagulation or antiplatelets. They say if it's extracranial, then you're rather going to use antiplatelets. So, and then you phone Fernandez if the patient has recurrent strokes. Personally, if this happens to me, please phone Fernandez anyway. Because I just think, if there's something to be fixed, I would like to have the chance. So if it's extracranial, he can possibly assist there. So then this is my other pet thing to ask for. So cerebral vein dural venous sinus thrombosis. So these patients typically come in with those high pressure headaches. So they say, doctor, it feels like there's hell of a pressure in my head. They can't lie flat. They have papilledema. We had a 13-year-old, when was that? Less than a month ago. So she was admitted with typical, it can sound exactly like a migraine. But the thing is, this is the first onset. She's 13 years old. So technically she should have had a scan. She didn't have a scan. She only had the scan about, I think it was 5 days later in the ward. So then they phoned me hysterically, saying, it's the biggest thrombus they've ever seen. So, what you then typically do is you need to, I can treat the headache, but we have to find the cause. So this specific young girl had, I think she had a factor Leiden deficiency or something. So you treat them and you start anticoagulation. So they do very well. I've actually seen about 3 times, and the thrombus is almost completely resolved. So they have a good prognosis. The other thing that you do for them, or she actually came and asked me a second time, doctor, can you please do a lumbar puncture for me? Because of the pressure, it's just, but very sweet kid, really knows her body, knew there was something wrong. And, like I say, I think it takes some guts to come and ask your neurologist to just please do you help me. It's like, But anyway, okay, then this you might see if Dr. In Dr. Lize's patients or in Oki's patients or So this is PRESS, posterior reversible encephalopathy syndrome. So these patients have very prominent visual symptoms. So they can have like a balance syndrome, which is they can have like nystagmus, they can have like visual hallucinations. And usually these patients have severe hypertension. They can have papilledema, they're encephalopathic, and then you have this is like the textbook presentation where you have subcortical white matter posterior enhancement on the flare. However, it can look slightly different in real life. So it can be anterior. And the other thing that I want to say, and I've seen this for myself, is even though the name says reversible, it's not always reversible. So sometimes patients have like significant cognitive impairment afterwards, or they can have seizures. So it's not always a happy ending, and especially if it happens recurrently. So in renal patients where it happens more than once, it can be a very sad story. Okay, then meningitis and encephalitis, and then I just want to add it brain abscess. So this also, I must say, meningitis is less common than you think in our setting. If you worked in a state hospital, you would probably see much more. But I just wanted to remind you how to look for meningism. So the knee is at the top. So what you do is you flex the knee and then you extend it, and then the patient says, ouch. So that is the knee. And then at the bottom is the Brzezinski, where you passively try and just flex the neck, and then the patient will flex their knees. So it is not a neck spasm. It is not a neck that some person that was drunk, but it's not that. it's like a proper stiff neck. And the kind of meningitis depends on the age of the patient. So in the older patients, you would think like viral things, like zoster or herpes. And then in the younger patients, if a patient is from Porch, they will have meningococcal meningitis. I think it's otherwise. So just like it. Okay. And then I thought, you can also, of course, if it's meningococcal, you can look for other features, rashes, whatever, but they don't always have it. And then if you do that lumbar puncture, your heart stops because it's this turbid pus that you're actually draining. So it is quite something to see on meningococcal. And then just the abscesses, we don't see that many abscesses, I must say. I touch wood, I will most likely see one today, but the abscesses, typically there's edema around the lesion. If you give contrast, it's a nice little round rim and with a necrotic center. So that's the typical abscess. So this other thing not to miss. So a patient with history of cancer. So the patient comes in and tells you, doctor, I have malignant melanoma, believe them. so this is actually a real patient. So he came in, had a seizure, then went into a coma and sort of never woke again. I think the main thing, if you see one of these patients that has a tumor, is to give them Decadron because of the edema that's usually around. So you could just calm down the swelling, and then you can, of course, load them with an anti-epileptic for what it's worth and keep them sort of just stable. But unfortunately, it's not always a happy ending. It's never really a happy ending with malignant melanoma, but such is life. Okay. Then intracranial bleeds, like I said, with our old age homes around, be careful. Some patients, they also forget that they've fallen into the hospice. Like, on the grass, there's always like gardening involved as well. So be extremely careful, especially if they're on an anticoagulant. So these patients, like I said, they come in with just progressive, very subtle decline, and then suddenly there's drama. The typical epidural is that biconcave look. You can see that already, and then you find the neurosurgeon, and hopefully they can drain it for you, or they can just have a subdural, which I guess is the better one to have. So if you had to choose one. And then I just wanted to say with idiopathic intracranial hypertension. So these patients, they shouldn't be presenting to you guys, but you might see them. So it's typically a slightly over, I think for now I've diagnosed a couple of them. So it's an obese female, usually childbearing age. They come in with transient visual obscurations, TVOs, or double vision, or they can tell you their peripheral vision is not like they get into car accidents because they have like tunnel vision or they have no peripheral vision. So when you look in their eyes are swollen, they can have a cranial nerve 6 palsy. They can have visual deficits because there's actually pressure on the nerve itself, and they typically also have tinnitus. When you do the lumbar puncture, the opening pressure is typically more than 20, but with our very special manometers, it's always 22, which I don't know what to do with. So the new guidelines, you know what? There is this school of thought. Even if you do a lumbar puncture and I don't know how you'll get ethics for a study like this, but if you do a lumbar puncture on a patient with a migraine, the pressure should also be slightly up. So I want the pressure to be at least more than 25 before I put my head on a block. Otherwise, I give them Topamax, which also reduces intracranial pressure and helps with migraine. And then I tell them to lose weight. But there's this vague area between 20 and 25 that just makes me uncomfortable to just call it this. So if there's no other features, so if there's not, for example, slit-like ventricles, flattening of the posterior part of the eye, like torches, so like optic nerves, or like a proper empty sala, and it's like a borderline opening pressure, I am usually very careful to just label these patients. So in terms of treatment, like I said, we actually treat them with Diamox or Azimet that we use for ultra-fluid sickness to just reduce the amount of fluid being produced. So that's the one thing. The other option is Toplep, the anti-epileptic, which we also use for migraine, which has a similar kind of mode of action. However, you shouldn't actually use them together because they can give you kidney stones. So just know that it's not the ideal thing to do. And then they say actually these patients have like this sweet spot of weight that they need to lose. So typically it's between 5 and 10 kilos. If they lose it, then actually you can stop the medication and it goes away completely. But then you have this subclass of patients who for some reason cannot lose weight. They can, or if they lose the weight, it just never improves. And then they have to have a shot. So it's neurosurgery, so I try always to not get there. I mean, it's better to make just a tiny lifestyle change, but unfortunately, that's sometimes how it goes. So if you do see this on the scan, patient has symptoms, then admit and then we'll sort them out. So yeah, but it shouldn't be come to casualty, but sometimes it does because these patients, they go for a routine eye test typically, and then the optometrist tells them go to the hospital because of the papilledema usually. Okay, then the hypotension, and I have to say here, this is usually due to a lumbar puncture. Mostly, there are idiopathic intracranial hypertension patients, but it's very rare. So usually these patients, after we've done a lumbar puncture, it's usually on day 3 of the lumbar puncture, the patient will say that I have a severe headache. When I get up, it resolves completely when I lie flat. And then you tell them, okay, then continue lying flat for at least another week. I apologize. but it is a known side effect post-LP, so I always counsel the patients. Usually Valsalva or exacerbates it the moment you do that. Usually when they go to the toilet, they will burst out on the toilet. Then they can have tinnitus, they can have meningism, like severe neck pain, and then they can have nausea and vomiting. The neurological examination is usually normal. And the way that we treat it is with caffeine. This is the one headache that you treat with Red Bull. Or there's a tablet called Dragmarker. So it's 150 milligrams of caffeine, and you can give it 3 times a day. And you tell the patient just lie in bed for another couple of days. These patients typically, if there's not a hysterical mother or spouse, they resolve within like 3 days. But the moment that there's hysteria involved, it might never resolve. But luckily, touch wood again, I've had only one patient that I had to beg a neurosurgeon to do a blood patch for. But which is basically what they do is they take your own blood and then they inject it where you did the LP, and the theory is that it just causes a plug and it stops leaking. So, but anyway. So then this, I didn't actually know. So I learned something last night. So acute narrow angle glaucoma. So this looks scary. If you see that, please don't phone me. So a patient coming in with severe eye pain, red, teary eye, and then the giveaway is the fact that the pupil is sort of mid-sized, and it doesn't dilate, it doesn't react to light. And then you phone Dr. Dairam, or you phone Centurion Eye, or whoever else, because they need to go and do some laser iridot their premium, something like that. Okay, and then this is also just something because we're working with the older generations, giant cell arthritis. This is not something you want to miss. So, in a patient more than 50 years of age, with abrupt onset of visual disturbances, so they typically also have like what looks like basically a stroke of the eye. They have that, and then they have claudication of the jaw, and they can have fever. So when you palpate, I have never been able to palpate this, but anyway, apparently you should be able to feel nodular temporal arteries. Technically, overseas, what they do is they can do a sonar, and they can actually see these little, I don't know, nodules. I've not seen that in South Africa happening, not at the academic facility and not at this facility. So what you do then is you phone Fernandez again and you ask him to just take out the artery and then you send it away. And then that is quite helpful. You have your diagnosis. The patients typically have to go and see a rheumatologist. They typically have to go onto cortisone. You treat them with cortisone. And there can be like a, rheumatologica. There can be an overlap with all of the other myalgia, rheumatic myalgia presentation as well. But they, so what they typically say is you would give them a pulse of steroids and then you would wean it over a while. And if it recurs, then you would start your Imuran, etc. But that's also for rheumatology to treat. So take home messages. Sorry, I kept you busy for a while. But most headaches are actually benign. You can rest assured. Most of the time, it won't kill the patient. Snoop 10, all of them. Get a good history, examine your patient, do the scan. We're in a facility with a scan, do the scan, and then you treat them appropriately. Try not to over-treat because you can see the patient is in pain and you think the biggest gun, this patient needs Targenac, they need morphine. We don't do that anymore. Just calm down, make the patient calm and give them just the correct treatment. And most of them will actually get much better. So that's it.
Thank you. Thank you so much. Can I ask you a question about the tryptophan that you give to prevent? Is it something that you titrate up, or what dosage do you go for?
So what I usually say to patients is I start them. I have to say in public sector we only have 25 milligrams. So you would actually break it, or you would it's a very difficult thing to break. So but or you would start on 25 milligrams. In public, I found patients really struggle sometimes with tryptophan. So they say I'm groggy for the next 3 days or whatever. So I usually warn the patient. I usually start them on 10 milligrams, and then I tell them, let's just first take it for 3 days and see how you feel. Tryptophan should be taken 3 hours before bedtime, so they shouldn't go to bed at 12 and then take it at 12 and then think they can wake up at 6 and be normal. No. So you have to tell them how to take it. And then what I usually say is if you can tolerate it, then first just take 2 for me at night. And then the next time I would review them, I would actually go to 25 if they tolerate it well.
Okay.
And then the headache doses or the dose that's recommended is not more than 50 milligrams. So you can push them up to 50 milligrams if they tolerate it well. But I've not met someone that can tolerate it that well that I can go to 50.
Okay, yeah, that's also my experience. And some of them find it very sedating. And then unfortunately you also often see weight gain.
So that's the thing. And in all the patients, there can be a bit of cognitive side effects as well. So I usually try and like see what the rest of the patient looks like. So
individualize.
If it's a very anxious patient or a patient in menopause, then I would rather give something like Venlor. It's going to help for the flushes, plus it's going to help for the migraine.
Right.
So you try and sort of just use one drug for many purposes.
That's very good one.